here at DJ Tribe for about 3 years now. And in my capacity here as a research scholar, I work with Kathy Sikkema's team. And Kathy, by the way, sends her regrets she wasn't able to be here today. And in that role, I do kind of two things. One is that I coordinate the Social Behavioral Sciences Corps for the Duke Center for AIDS Research. And I know several of you through that capacity. And then I work as an investigator across several NIH-funded studies. And what I'm going to present today is one that is particularly close to my heart and that I've really enjoyed working on because it kind of combines a lot of my background and takes me back to South Africa, where I lived and worked for about 4 years. I went to South Africa in 1999. I had done my undergraduate degree in African Studies and my master's in gender and development. And while I was at Sussex doing my master's, sort of through the way things work, I got connected with an organization in Ireland who then hired me to work with the United Nations in South Africa for a 2-year stint, working as a gender specialist within the UN system in South Africa. And this was 1999. It was I arrived just a few months after Thabo Mbeki had taken leadership as the second democratically elected president in South Africa. Mandela had really focused, of course, on sort of building democracy and building community post-apartheid. And Mbeki then was left with sort of trying to grapple with and deal with the HIV epidemic in the country. As we know, he ultimately did not do that well at all. But when I arrived in 1999, there was just a lot of sort of trying to figure out what that response would be like. And one of the roles I played was to help the UN to kind of make sure that gender was integrated into our support and our capacity building of the South African government. I then afterwards, I worked at the UN for 2 years and then worked for a couple of years for a South African NGO and helped to coordinate a national survey on sexual violence and HIV risk in schools among youth in South Africa. And so traveled with a team of field workers around the country and really got to understand kind of some of the issues that South Africa was dealing with, not from a policy level, but really on the ground. So when I first got to know Kathy several years ago, we were talking about this study that she was getting off the ground, and it just seemed like an excellent fit. And so I've been on board with her since 2008 when this study started, and sort of helping to coordinate the study and working as an investigator on the study. So this study is looking at the context of HIV risk among women who drink in bars and shebeens in a South African township. And we're specifically working in Cape Town. It's funded by the National Institute of Alcohol Abuse. It's a 5-year R01 study and is led by a multiple PI mechanism with Duke, University of Connecticut, and University of Stellenbosch in South Africa. So this slide is probably not new to you, but I think it's important to just begin by giving a context of the extent of HIV prevalence in South Africa. This is the most recent antenatal sentinel survey results. All pregnant women at certain sentinel sites are assessed for their HIV prevalence, and that goes into kind of understanding the demographics of HIV in South Africa. And in the most recent antenatal sentinel survey, 30% of pregnant South African women were HIV infected. And that the prevalence varies throughout the country, as you can see, anywhere from 40% in the province of KwaZulu-Natal, and actually the lowest prevalence in the Western Cape, which is where we're working on this study. Cape Town's prevalence is about 18% adult prevalence. So just remember, this is pregnant women, right? So when you extrapolate it to a national survey, it's about 17% of the population, of the adult population, is HIV infected in South Africa. What we have seen in South Africa, though, is that prevalence has increased each year in the antenatal sentinel survey, and that there are pockets in South Africa where HIV prevalence is similar to other parts of the country, particularly pockets that are sort of heavily urban and poor townships. So HIV is oftentimes called a feminized epidemic in Africa, and this slide just shows why that's the case. if you look at it, women are getting infected at much earlier ages and at far higher rates than you have among men. And you can imagine some of the reasons for that, right? First of all, women are more biologically susceptible to HIV. But beyond that, it has to do with sexual mixing patterns and patterns of relationship formation. Audrey Pettifor at UNC recently did a study that showed that the risk behaviors are not all that different among adolescents and young people in the U.S. compared to South Africa, but that there are certain patterns of mixing where young women are having sexual partnerships with older men that contributes to some of these age discrepancies and gender discrepancies. And there's a large body of qualitative research that also shows that for these young women, a lot of their first sexual encounters and subsequent sexual encounters are forced or coerced. So oftentimes happening, therefore, in a context in which the women themselves are not having much control in those relationships. So in this study, we're asking a question of what contributes to sexual risk behavior and therefore contributes to vulnerability to HIV infection. This question obviously isn't new, but what's novel about this is that we're asking this question about women who attend drinking venues in a township, an urban township in South Africa. And we are interested particularly in a couple factors that we think might influence it. We're interested in alcohol use and addiction, the role of poverty, trauma, and resultant mental health, violence against women, and gender inequalities. So alcohol use in South Africa is interesting in that it's not highly prevalent, but if you just look among drinkers, it actually has one of the highest rates of alcohol consumption globally. So consider this, 16% of women only have used alcohol in the past year, but in the past weekend, 25% of those drinkers have drunk to harmful levels. And in townships, drinking happens in shebeens and in taverns. So shebeens are sort of informal bars and generally unlicensed, and taverns are slightly larger and licensed venues. These pictures on the side just kind of, I think, illustrate better than any statistics of what poverty is like in South Africa. South Africa has a GNI per capita of 6,000, making it an upper middle income country. However, it has the disparities in South Africa are huge. This is a picture at the top that's taken from outside of our office in the township of Delft where we're working. And the bottom picture is taken from outside of my hotel where I stay in town. So if you just look and you have Table Mountain in the background in both of them, but it's just completely different worlds. And anyone who has been to South Africa or spent time there is just very aware that really these two worlds are kind of coexisting in one country. The Gini coefficient of South Africa is 0.72. Gini coefficient measures the extent of equality or inequality ranging from 0 to 1. Compare that to the U.S., 0.38. And Brazil, which is oftentimes compared to South Africa in terms of its inequality, is 0.57. So it's much higher levels of inequality than Brazil, for example. And of course, poverty has very much sort of the distribution of wealth follows racial lines, which comes from many decades of apartheid rule in South Africa. The life expectancy of 52 years is really as a result, in large part, of the impact of HIV in the country. Violence, including child abuse, domestic violence, and crime are widespread and give South Africa oftentimes a reputation of being one of the most violent countries in the world. When we try to look at sort of what do we know about mental health distress in the population at a population level, unfortunately there just isn't that much data out there. There was one household survey that put lifetime depression prevalence at 10%, past year at 5%. Those are rates that you can imagine are lower than the U.S. And slightly elevated rates of PTSD in primary care settings. But again, we're just lacking data on this information in South Africa. Over half of South African women have experienced gender-based violence, and that's been shown in several different studies that have been done. And alcohol use and gender-based violence are closely linked, and that has both biological reasons because of disinhibition, enhancing emotional responses, as well as a social role that alcohol oftentimes gives men permission to express culturally bound norms of male dominance. And gender-based violence has also been related to HIV risk because within the context of violent relationships, women don't have the ability or capacity to kind of assert risk reduction behaviors. So the aim of this study then is to understand the context of HIV risk among women who attend drinking venues in one township in Cape Town. And in particular, we're trying to understand how these factors influence sexual risk and therefore vulnerability to HIV in this setting. So the setting itself is a peri-urban township in Cape Town. It's an interesting township because it was established in the early 1990s, so right at the end of as apartheid was ending. It was a mixed race setting, so unlike other townships that might be either colored or black, this township really has an equal number of people who self-identify as black or colored. And colored is an ethnic group unique to South Africa that is historically of mixed race and primarily Afrikaans speaking. And the African population in this area is primarily Xhosa speaking, coming from the Eastern Cape. So we're working in 12 alcohol serving venues that we systematically identified using something called the PLACE methodology. And the PLACE methodology was developed by Sharon Weir at UNC in the Department of Epidemiology and the Population Center. And it uses community intercept surveys in order to identify places that are high risk for future intervention or research. So our team went out and they did surveys at bus stops and on the streets, trying to identify places that people drink. And then they visited these venues and assessed for eligibility. And we selected venues to represent some diversity in size of venues as well as dominant ethnic patrons in the venues. So the methods that we're using are longitudinal and multi-method. And it's a little bit complex, the set of methods, so I'll go through it. I'll go through all of them. We're combining quantitative methods and qualitative methods, all in the bar setting. And the quantitative methods that we're using include a cross-sectional survey that's conducted with both men and women in the bars. So our team, who are matched by race and language to the venues, go into these bars every 4 months for a week-long period. And they have a pile of surveys, and they walk up to patrons and ask patrons to complete the survey. They do oral consent and make sure that the person has some privacy to complete it. And ideally, has not begun drinking for the evening. But we see, when you visit these bars, you see people lined up at like 9 o'clock when the doors open. So
A.M.?
A.M. So drinking is heavy, and it happens starting fairly early. The interview itself is a brief 15-minute structured survey. Most people choose to self-complete the survey, but we do give an option of interviewer administered. And we aim to have universal coverage by convenience sample, or at least 75% of the patrons on any given evening to complete this survey. So at the end of collecting this data across the 12 venues, 4 time points in each venue, we expect to have a sample size of about 6,400. We are not linking people for obvious reasons. It's de-identified and anonymous, so we're not linking people across time, but we do ask a single question about whether they have ever completed this survey before. So we're able to look at it both kind of as panels of patrons, or we're able to look at it as one cross-sectional survey, eliminating people who have taken it previously in order to just look at unique respondents. So this is what the cross-sectional survey looks like. This is a front page that the interviewer would fill out and sort of some of the prompts that they would use for doing the oral consent. And the survey itself, then, people fill out themselves for the most part, and they fill out bubbles, and the field worker helps to instruct them on how to fill it out. And then we're able to go back to the office and just scan it into a scanner, and it goes directly into a database. Measures include substance use, trauma and mental health, sexual risk behaviors, mostly within the last 4-month period, HIV testing experiences, including if they're willing to share their HIV result of their most recent test, HIV stigma, and norms and attitudes, including social norms, attitudes towards violence against women. And our sample that we have to look at now includes about 3,700 people, both men and women, fairly evenly split, and also evenly split in terms of racial groups. About half of them only half of them have completed high school, and just over half are unemployed. 15% live in a house without electricity or water, which is pretty typical in this setting. Most people have government housing, and there's very common electricity or water, but there are definitely informal settlements where people build shacks behind other people's houses. And I think what's really important is that the majority of patrons who complete the survey live within a 15-minute walk of the venue. So what that means is that these venues are representing very distinct geographic areas. These are sort of neighborhood bars. And about half visit the bar at least weekly. So most people we talk to said, yeah, this is my bar. This is the place I go to. During that first cross-sectional period, the field workers identify women to enroll into a cohort that are followed over time. So in each venue, the idea is that about 50 women are recruited to be part of this cohort. And they come into the office. Our office in the township is actually located on the top of the library, so it's a very safe space. There's security guards around that are there for the library, and there's some other social service offices. And they come in and they complete their assessment at a computer. So it's a CASI, a computer-assisted interviewing. They put on headphones and they can choose to listen to the question in either Xhosa or Afrikaans or English. And they complete questions. It takes about 45 minutes. And the measures are very similar to what we're measuring in the cross-sectional survey. But the advantage, of course, is that we have more time and we can ask these questions in much more depth and use psychometrically informed measures to measure these constructs. And the cohort of women is a fairly similar makeup. I think it's interesting that a quarter are married, but the majority have children. Very few of these women have finished high school, and the large majority of women are unemployed. So at the same time that this data collection is going on, we're also doing qualitative data collection. And this includes individual in-depth interviews. So individual in-depth interviews are, as you can imagine, sort of one-on-one, guided by an interview guide. We record them and then transcribe them and translate them. And we have we expect at the end of the data collection period to have 160 in-depth interviews. For quantitative researchers, that doesn't look like much. Anybody who's done qualitative understands that this is actually a really big number. You can look at the notebooks of transcripts on my bookshelf. They're not this big now. So it's a large amount of data to work with. And when we trained the interviewers on how to do the qualitative interviewing, we trained them to use a real narrative approach. Because what we want to understand are the stories of these women and the context of their lives. What is their relationship with the bar? Why do they go there? What happens when they go there? What are their intimate relationships? What's their behavior within the context of that? Violence in the context of that. What do they think about HIV? How are they making decisions about condom use? So we're able to get much more of a context of these women's lives and understand the behavioral and cognitive processes. At the same time, our field workers are doing observations in the bars for 4 one-week blocks per year. And they go to the bar. This happens the week before they go in and do the cross-sectional survey. So we have a very sort of strict timeline. We work in these blocks of time that different events occur in each of the venues. And they go to the bar and they use an observation guide to make notes and do kind of ethnographic observation of patrons, their drinking behavior, other substances, how people are interacting with each other, and particularly we're interested in issues around sex and violence. So together, these methods make up our data set. And the results I'm going to talk about are 2 papers that use the quantitative data that look at the role of traumatic experiences in impacting risk in this setting, and particularly through this mechanism of mental health distress. And 2 papers that use the qualitative data that explore the broader context of the social and physical setting in which risk happens. So the first 2 papers, as I said, use the quantitative. The first paper uses the cross-sectional data and an early iteration of the cross-sectional data where we ask specific and more in-depth questions about mental health. And this paper we had published in JADES earlier this year. And in this paper, we were interested in examining traumatic experiences as they relate to mental health distress, and in turn, mental health distress as it relates to sexual risk behavior, particularly controlling for substance use in this setting where hazardous drinking is very, very predominant. And we had a data set at the time that we were working with that included 340 women. And I would say the paper in JADES, we actually publish results from women and men, and we report them separately, but just for the sake of time, I'm not going to present that here. So first, considering what the relationship is between traumatic experiences and mental health distress. This is what we found in terms of the traumatic experience reports of women in this setting. As you can see, about 1/3 had ever been hit by a sexual partner, 20% had been forced to have sex, 20% had a history of childhood physical abuse, 10% had a history of childhood sexual abuse, and about 5.5% said that they had been diagnosed with HIV in a recent HIV test. And we also have those figures for previous month. Our sense is that these are underreports, so just to keep in mind these surveys were completed in a bar setting, in a social setting, and so some of these are very sensitive questions, obviously. So I think if anything, we have some significant underreporting there. Mental health we measured with very brief screeners. That was given the limitation of the space on this cross-sectional survey that we were trying to do in 15 minutes. We used an adaptation of the PHQ-9, which is a common depression measure, something called the PHQ-2, which has only 2 items. And using that and the cutoff that's in the literature, 68% screened positive for depression. For PTSD, we used a 7-item scale, and given the cutoff, almost half screened positive for PTSD or post-traumatic stress disorder. So we considered first using bivariate logistic regression models, what factors influenced, to what extent experiences of traumatic events influenced depression and PTSD, or were associated with depression and PTSD. So each of these reports of odds ratios were different models. We did look at age and race as covariates, but it didn't change the results significantly. So as you can see, as we would expect, the experiences of having a traumatic event were strongly associated with having a positive screen for depression or PTSD. Sexually abused as a child didn't reach significance, but if you just look at sort of the pure numbers, it was twice as common among people screening for depression versus not depression, but there were not enough, perhaps, numbers in each of the cells to reach significance, and same with having an HIV positive diagnosis. So this is not surprising that having a history of traumatic experiences would be related with mental health distress. We were then interested in whether mental health distress had an impact on sexual risk behavior, and particularly controlling for substance abuse in this setting. So these are some results from the sexual behavior of this population. 48% had had any unprotected sex in the past 4 months. It was a mean of 1.22 partners, but ranged up to 24. and a mean number of unprotected sex acts of 5. That includes, of course, a lot of zeros in that number. So in order to examine this, we used a generalized linear model using negative binomial regression. So negative binomial regression is an approach that you would use to account for over-dispersion in your outcome variable. So because we had 50% of the population reported 0 unprotected intercourse occasions, which is our outcome, we needed to account for the fact that it's not normally distributed in our model. So when we did our model and we put alcohol frequency and quantity and drug use, so all these substance use variables in there, and also included depression and PTSD score, depression and PTSD stayed significant, even controlling for the impact of alcohol on unprotected intercourse occasions. So what this lends evidence to is that depression and PTSD might be an exposure that makes one more likely to have unprotected intercourse. So the second paper kind of expands on some of these results, and it uses the cohort data to look at PTSD as a mediator between traumatic experiences and drinking behavior. And we're planning on submitting this in a few weeks to the Journal of Studies of Alcohol and Drugs. And so this is our conceptual model. We used cohort women, about 560 of them. And here we were able in this computer assessment to use much more comprehensive measures to look at traumatic experiences. We used the conflict tactics scale to look at intimate partner violence, the childhood trauma questionnaire, and the WHO CD-PTSD section to assess some of these other more community-level violent exposures and experiences. And as you can see, the rates of lifetime traumatic experiences is very high. Alcohol consumption was also very high, and it reflects a lot of what the DHS data alludes to. That it's not necessarily that people are drinking frequently. Only 12% drink 4 or more times a week. But when people drink, they drink heavily. And so half of the women said that when they drink 5 or more drinks on an occasion. So this is considered sort of very hazardous drinking, particularly for women. And using a criteria for hazardous drinking of the audit, which is a WHO measure of hazardous drinking and alcohol consumption, and a very high cutoff of 16, a third of the population almost meets the criteria for hazardous drinking. So we looked then at whether these different categories were... yes.
So the hazardous drinking, that comes from having asked people, right?
Yes.
Do you think there might be some sort of a social norm about people sort of trying to show off how much you can drink? I'm thinking back in college days, if you asked any student how much you can drink.
My guess is it's probably the opposite direction in women because, you know, it's not, maybe if you ask people in a public setting that among drinkers, that might be different, but my guess is that in this setting, alcohol use among women is actually not very normative. I mean, as you saw from the DHS data, it's not a large proportion of women who drink. So I would think it actually might be an underrepresentation. That would be my guess.
Okay.
Yeah. Thanks. So we looked at these different categories of abuse and whether they were associated with hazardous drinking, and all of them, as you can see, the odds ratios are significant. So for most of these, that means that for most of these traumatic experiences, people who experienced the trauma were about twice as likely to be hazardous drinkers as opposed to people who did not experience the trauma. So we were then interested in the extent to which PTSD mediates this relationship between traumatic exposure and drinking behavior. There are things in the literature that show, and particularly from Kate Wetton's group, that show that increasing numbers of traumatic experiences or categories leads to greater risk behaviors. So we looked at a number of categories of traumatic exposure leading to higher levels of drinking behavior using the audit score and mediated by PTSD symptoms, which is a continuous measure. So first we just looked at these individual paths. And The path is the effect of traumatic experience, of exposure on PTSD, PTSD on drinking, and trauma on traumatic exposure on drinking behavior. And we're using a series of linear regressions. So then you see this number changes because the next step in examining mediation is to look at the impact of traumatic exposure on drinking behavior controlling for PTSD symptoms. So the path decreases and at a significant rate. And so that lends evidence to mediation, that PTSD is accounting for a large portion of this relationship between trauma and drinking. And we were actually able to calculate the proportion mediated, and that's 0.46. That means that almost half of the effect of traumatic exposure on drinking behavior can be explained because of development and increased elevated rates of PTSD symptoms.
What's the rest of it?
Sorry?
What do you think?
What else?
Yeah, what else?
Right.
You may have said this already, and I came in late, I apologize, but what are PTSD symptoms specifically? And so what are the things, what are the ways in which they're not mediated by those symptoms?
Right. Well, so I think there are a couple things. One is that you don't have to develop PTSD symptoms from experiencing a traumatic event. And so you may not develop the PTSD symptoms, but still your traumatic experience, the way you're coping with that may still lead to elevated drinking behavior. So it's not necessarily needs to be explained by PTSD. PTSD symptoms, it's their standard PTSD measures. They have to do with hyperarousal, avoidance. There are a couple of different constructs that are measured, but they're sort of they're cognitive and sort of a lot of behavioral responses. Can that answer your question? Mm-hmm. Yeah. So to summarize the quantitative findings, as presented in both of the papers, the experience of trauma and violence in this setting is extremely high, and as is drinking among women in this setting. And what we think is that it's likely related to coping with those traumatic experiences and coping from the resultant traumatic symptoms that arise from having those experiences. And traumatic experiences and mental health distress, as we've shown, influence women's behavior and therefore put them at risk for HIV. So the next two papers I'll present on come from the qualitative data, and both of these papers draw on both the in-depth interviews and the observations in the bar setting. So the first is looking at alcohol-serving venues as sites of risk and potential protection for gender-based violence. This is a paper that I just resubmitted to Drug and Alcohol Dependence. And it uses data from the first 6 venues, which is what we had at the time. The in-depth interviews from 31 women, 13 men, and 11 staff. And a lot of those interviews, we had repeat interviews for about half of that sample. The observations and the debriefing transcripts. These are after each observation week, the field workers would sit down with the local South African PI and just talk about the venues, their impressions, their experiences, in order to document that, and it was transcribed and became part of the field notes. The analysis that we took is a grounded theory approach, and this is a theoretical approach in qualitative data analysis that really lets theoretical constructs emerge from the data itself. And one way that we did this is that we wrote analytic memos on each of the transcripts to summarize the narrative and to identify what are called in vivo themes, in vivo code. So these are sort of words that participant use themselves that we think sort of summarize these overarching constructs. And we used Atlas TI to code the memos related to our output. Atlas TI is one of several qualitative software programs that are available. But a lot of the Atlas TI is really, and software is really the last step in qualitative analysis. But it really is a process of reading and digesting and thinking through and fitting it into a larger picture and a larger narrative. So the findings on this paper related to gender-based violence, as I said, are both that venues contribute to gender-based violence and also that they have some type of potential to provide protection in this setting. So there were four sort of themes related to venues contributing to gender-based violence. The first is that alcohol contributed to aggressiveness and sexual violence, and this has been documented in a lot of different settings. This man says alcohol gives our men strength. It's what causes the argument. So in other words, when people drink, they're more likely to be assertive. And we found that actually with women and men. What was interesting, though, is when women drank and became assertive, that actually made them more vulnerable to receiving violence themselves. It then became a very, very reciprocal form of violence. Venues also reinforce negative attitudes towards women. Venues were very much associated with women who attended venues were sort of looking for sex partners. They were loose women. They were not good women. And so women who came to the bars also oftentimes became subject to violence from their partners because they were seen as sort of straying from the relationship. So this woman says, my boyfriend comes looking for me at the shebeen and asks why I sit so late. Then he starts hitting me with sticks with his fists. And there were several observations that our field workers saw in the bars of men coming to the venue looking for their girlfriends or their wives and starting to beat her up or drag her out by her hair because they saw her attending the venue as infidelity. Women also risk sexual violence leaving the venues. People drink into the evening, of course, and when they leave the bars, these are sites where there's not a lot of great street lighting, there's not community-level policing. Sometimes when there is community-level policing, you have to be afraid of the police. And so women talked about how they're oftentimes sort of preyed upon when they leave the venues. And they're also oftentimes put into a situation where they need to accept a ride from a man or a walk home from a man who then actually turns against her. And so she kind of risks violence no matter which way she goes. And of course, in the context of intoxication, women are particularly vulnerable to sexual violence. People also talk about owners tolerating and perpetuating gender-based violence, and there were a lot of incidences of owners being observed actually being violent towards their own wives in the venues. There was one venue where the husband regularly beat his wife up at the venue itself, and so they sort of exhibited this. They were this role model of endorsing violence against women. So at the same time, people told us that venues have the potential as sites for women to avoid gender-based violence. And when we asked women across all of the venues, why do you go to this venue? People said, I feel safe here. It's a safe place to go. And I think that issue of safety needs to be understood in the setting of much bigger risk, because women might feel safer in this venue because the streets are dangerous and her home is dangerous because she might be subject to domestic violence. And so going to the venue, at least you have some type of protection and there's a public setting. So this woman says about her boyfriend, he's very well behaved at the bar. The problems start when we get home. And you behave yourself because tomorrow what are the neighbors going to say? So in other words, the public setting provides some protection for these women that they might not otherwise have. The second, which contradicts with what we talked about in terms of risk, is that owners did show some potential for positive influence. And one of the ways they did that is just because of the discipline that they enforced in the bars. This is their business, it's their livelihood, and it's really important to them to, as they say, keep the gangsters out and keep people out who are going to be causing trouble. So women feel safer sometimes in the bars than they do on the streets or in other settings because the owners don't allow it. And there were a couple instances where owners talked about how they, and patrons as well, talked about how they see themselves as something of a confidant and a support system for their customers. this owner said, if something bothers you, just come to me, we'll sort it out. That's what he tells his patrons. Yeah.
Are any of the shippings owned by women?
There are actually a couple that are run by women, and the two that are run by women that we're working in now, so these venues, pretty sure all had male owners / managers. But it'll be interesting to look at when it's run by women, what the difference is. You oftentimes, though, you do often have, even in these bars, you have men who are the owners and women who sort of manage it and run it on a day-to-day basis. People didn't necessarily talk about sort of that being a positive influence or seeing this woman as a role model or a protector. I think she was very much like, there's this role of sort of the female businesswoman who doesn't kind of meddle and perhaps might be less likely to meddle than a sort of male owner or manager, which is kind of an interesting phenomenon. But yeah, so these are the findings related to both risk and protection for gender-based violence in these venues. The next paper that I'll talk about, this is the final paper I'll talk about, is one that we have looked at alcohol as a currency for transactional sex and sexual exchange in these venues. And the methods are very similar. We used the same data to examine this. And the four themes that we identified are sort of used as headings these in vivo quotes, these quotes that we think sort of summarize this theme that kind of emerged across the data. And the first is a quote from a woman, because he has bought for her, he wants to sleep with her. And this reflects just this dynamic that happens within the bar, that acceptance of alcohol, purchase of alcohol by a man and acceptance of alcohol by a woman equals sexual access. This man says, you drink from me, I also drink from you. So it shows sort of this reciprocal, this is an exchange. This is your currency is alcohol as the man, my currency as the woman is sex, and we make that exchange. And remember, in this setting, women are much less likely to be employed. So I think this is where gendered poverty really comes into play with creating risk. So there's this implicit agreement. This is sort of the sexual script we heard again and again across these interviews. At the same time, you heard women talk about how they manipulate this social script. They know it, they accept it, but they use it for their own good and to express a sense of agency. And what this usually involves, instead of flirtation, drinking, and sex, it involves flirtation, drinking, and escaping. So somehow sort of getting out of the situation. And women use these words to describe it. Psychologically playing men, milking them, hassling, parasitic moves, crisscrossing, seeking victims. So it was something very deliberate on their behalf, and something that they did as groups of women sometimes individually, and would sort of use this to their own benefit and expressed it when they talked about it very proudly. However, even when women sort of exhibited agency through this process, still this norm of transactional sex and the alcohol sex exchange was associated with the undervaluing of women, and it reinforced the commoditization of women. So these are quotes from men. They're both basically what they imply, and what men often talk about is, I just want true love, I want passion, I'm just out to like have a good time, but these women are out there to get me. They're out there to sort of take advantage of me. And so men talk about really being taken advantage of. Women are gold diggers. The girls would like to end the weekend drunk. No matter how she gets drunk, they just want someone with money. So they are actually express that they feel very taken advantage of in this situation. So it leads to these sort of labels of women as whores, or other labels that devalue women. And then, of course, with regards to HIV risk, this alcohol-sex exchange contributes to HIV risk. There's obviously forced sex when a woman doesn't comply with this expectation that she sort of gives sexual access or sexual favors to a man who buys her drinks. There are multiple and concurrent partnerships. And I think it's also very important for looking at men. If men have money in their pockets, that basically means they have access to sexual partners because they can buy women drinks. And of course it leads to inconsistent condom use, both in terms of ability to ask for condoms when you've already sort of accepted someone's drink and agreed to this before you've had any opportunity to negotiate condoms, and of course in the context of high drinking. So to summarize the qualitative findings, context matters for HIV risk, both the social context and the physical context. And the bar settings can be sites for both risk and also potential agency and protection. And it's very important to understand the poverty and the gender inequality that contributes to that. Behavior may be some type of logical reaction to a socioeconomic environment. And I mean, that you can see it in the gender-based violence paper, sort of women talking about safety even in what is very objectively a site of high risk. And in the transactional sex paper, that women are sort of don't have money. They want to participate in this social milieu. And so they're using what is sort of their only currency to participate in this, their sexuality and their sexual access in order to be part of this environment. And there's also a lot of indications that vulnerability to HIV risk behavior is heightened by addiction. And I think that's particularly the case. We don't have any firm data to back it up from the from the transactional sex paper, but we do think a lot of the motivation for engaging in this transactional sex behavior is because of addiction to alcohol. So these are the results that I've presented. And the implications are that HIV risk reduction needs to address the context of women's lives, needs to understand these high rates of traumatic experiences, the relationship violence and control that might impede sexual risk reduction measures, mental health distress that might make people willing to take risks now because they don't have a strong sense of their future and their own well-being. Drinking and addiction, the role that plays in poverty and inequality. So the bar setting, we feel, can be an important site for HIV interventions. That there's a need to address gender norms, and that needs to happen with both men and women, to provide social support for women, to give them addiction treatment, to ensure greater safety measures both inside the bar and immediately outside the bar. And the bar owners have some potential to be engaged. I mean, even if you just look at sort of how the bar owners often talked about how they see themselves as sort of community leaders and there for their patrons. They express that they might be willing to be engaged. And at the same time, much broader structural interventions are needed. There need to be greater opportunities for recreation and productivity. A lot of times people are going to the bars and drinking because there's nothing else to do. And they're also going to the bars and drinking because they are dealing with general stress in their lives. They're dealing with crowded households. They're dealing with children who they don't see much future for, abusive relationships that break down, lack of education. They're much broader social and structural issues that need to be addressed. Prevention of abuse, both child and adult abuse, mental health treatment and prevention at a community level. So future analysis and papers, we have, because we have such a large data set in both qualitative and quantitative data, here at Duke there are several papers that we're working on. I'm working with Christina on a paper on methamphetamine use, which is quite common in this township, especially among the colored community, and trying to understand how meth use contributes to HIV risk behavior. Using the qualitative data to look at alcohol as a means to cope with trauma, stress, and poverty, the role of drinkers as parents, how they relate to their children, and particularly what potential there might be to engage with women as mothers and engaging with using that kind of as a motivator to reduce drinking behavior. Definitions of forced sex and differences among men and women. We interestingly found very high rates of forced sex among men in the cross-sectional survey, which we're trying to sort through and figure out. And we have grant applications that are either submitted or planned. Christina has submitted an RO3 to NIDA and a CFAR small grant to examine sexual risk in relation to meth use in Cape Town. So that would be building upon some of the infrastructure we've established in this study and some of the preliminary data we found. And together with Kathy, we're looking at an R21 to adapt and test a trauma intervention for HIV positive women based on some of the work that she's done in the U.S. So finally, acknowledgments. I want to, of course, acknowledge Kathy, who is my mentor, and Christina, Jessica, Francis, who are all part of our team, and Krista, who's a postdoc here, the other PI, Seth and Donald, Desiree, who leads our fieldwork, our wonderful fieldwork team, the study itself, and then CFAR. And this is my contact information, and I'll just end with a few pictures from our work in Cape Town. And I'm happy to take it.
Yeah, I just have a question. I was wondering why, I guess, you chose the setting to conduct the study, because it seems like with the age group of women that you targeted, they were rather young, and I feel like these kind of social behaviors and norms would be something that's very universal and sort of common among women, even in the U.S., especially college age groups, and that kind of thing. It seems like this whole dynamic occurs a lot. So I was wondering why you chose this setting rather than I feel like something could probably even be at Duke University, get so. Right.
I mean, I think that is true. One of the reasons we chose this setting is just because of the high rates of HIV in this setting. So factors that influence HIV risk are really important to understand and to then understand how to intervene in this setting. Why this particular community and township? Cape Town has a long history of drinking behavior, partly because if you know Cape Town, there are these gorgeous vineyards around Cape Town City, and people from this area would work in the vineyards, and then in exchange be paid in alcohol. So it has one of the highest rates, for example, of fetal alcohol syndrome globally. And we were interested in working in a mixed race township in order to look at some of the racial differences as well. So I would agree with you. I think there are lots of places where the same topic can be and is being explored. But hopefully we're sort of contributing to this understanding the setting.
So your PHQ2, I think, screener had 60+% screening positive.
It's highly sensitive, right? So it's picking up everything and more. It's not the best. We have a better depression measure in our cohort assessment because this was from our cross-sectional assessment where we were very limited. So it's an over-representation, I think, of sort of true clinical depression in this setting, but does provide, it's been validated as a good screening measure in the U.S., which is why we chose to use it.
Has it been used in South Africa and others?
It hasn't been used in South Africa. The PHQ-9 has, but this PHQ-2 is not. So we did translations and back translations, but no, it's the first time as far as I know that it's been used in South Africa.
Give us a rough sense of what those questions are?
I can tell you. They are, ask participants whether or not in the last month they had been often bothered by feeling down, depressed, or hopeless, and often bothered by little interest or pleasure in doing things. So those are two items from the PHQ-9. Answering yes to either of those questions leads to a positive screen for depression. So, as I said, very highly sensitive. Elisa.
It sounds like you're not measuring this formally, but kind of anecdotally, what have you noticed is the impact of your presence and questions?
Actually, we're not, but we're getting a lot of feedback from it. So, remember, we have these teams, and these are sort of these very dynamic young researchers, and none of them are from this community, this township per se, but they're from sort of surrounding communities. And they are going into these bars. They're basically in the bars for 2 weeks every 4 months. So a week of observation, a week of cross-sectional. And, you know, when I read the transcripts, people say, thank you so much for being here. I've learned so much, and you've really raised my awareness. So I think it's something, it's interesting, because in some ways, you know, research, you want to always be objective, right? But research also, hopefully, has some, its presence also has some kind of influence. And particularly, I think, qualitative interviews. I mean, you know, we have women who do interviews, and they're breaking down, crying, and talking about things they've never talked about before. And there's a lot of similarities between a qualitative interview and a sort of therapeutic session, right? And a clinical interview. So my guess would be that it's actually had a big impact for these women, and they're also, you know, they're coming to our offices to do the assessments. They're building some type of community that has nothing to do, maybe started at the bar, but suddenly has this other setting, and so it's a good question, because I think that's not necessarily something we're documenting, obviously, but has come up and we've gotten feedback on.
Just to follow up on that, I wasn't sure how much of the observational data is used in this analysis, but is it impossible that the presence of the observers is changing the behavior that is being observed?
Yeah. I think it would be impossible not to, but I do think like that the sustained presence maybe then, you know, eventually becomes normalized. I think the first time they see these folks, it's like, whoa, you know, who are the new people? And especially our female field workers get more attention than they would like. And then over time, they kind of just blend into the scenery. And what we hope is that we are observing a natural environment. But I think I think you always have to assume that you're having an influence in that environment that you're observing.
I mean, don't they have notebooks and they're writing?
They have notebooks, they're sitting, they're not drinking alcohol. Right. That's what they've been told.
That's what you're doing.
Yeah, exactly. They get some money for sodas. So they're not like fully participating, right? But they also have people come up and chat with them, like, you know, people come to the bar, they come to the bar a couple times a week, like, and you see a new face, and it's really exciting. And so you start to have conversations, and they certainly start to have conversations about HIV and about violence and gender, and, you know, they ask why you're here. They start talking. They share some of their experiences. So it definitely has an influence. I mean, we can hope it's a good influence, but we can also hope it's an influence that isn't like biasing our results to the point that we don't understand the settings as they naturally exist.
In some sense, you could also try and look for that Hawthorne effect in some sense.
Yeah.
If in your notes you find that, you know, drinking goes down and then it climbs back up, that's exactly what you would.
Yeah, right.
So you can actually test for that.
Right. That's true. We could look at that. Hard to know, like the seasonal effects versus.
But within a couple of week period, I don't know.
Yeah, that's true. Over days, yeah.
They've done these kinds of studies in medical settings. For primary care, you go and sit and you see that doctor changes behavior, but
right. You're on your best behavior, and then you just
it's too far.
Too much work.